So good afternoon again to the Markey Cancer Center affiliate network. Definitely a pleasure and an honor to be here as a recent graduate of the sociology department at UK. I'd also like to acknowledge the new Center for Health Equity Transformation and Dr. Nancy Schoenberg and Dr. Carrie Oser and Ariel Arthur for all the wonderful work that they're doing. At UK, as well as the Dream Scholars Program. I'll be joining the faculty at UAB in the fall, so I'm really looking forward to that. But my research interests, they largely revolve around racism and health. And in adherence to the guidelines that were set forth by our public health officials, I've been in the house for the past couple of months, so I won't be presenting any primary data that I've collected, but instead I'm going to invite you all to join me in a discussion about the differences in COVID-19 outcomes, particularly along racial and ethnic lines. Now, back in March, the virus was initially discussed as the great equalizer that did not discriminate, without serious consideration of the uneven distribution of risk for the virus among different groups. And I apologize if there are any Madonna fans watching this, but I just wanted to read what she said during a video that she posted on Instagram back in. It's nothing personal against Madonna because her sentiments reflected many who are in the public sphere. So what she said was, that's the thing about COVID-19. It doesn't care how rich you are, how famous you are, how funny you are, how smart you are, where you live, how old you are, what amazing stories you can tell. It's the great equalizer. And what's terrible about it is what's great about it. What's terrible about it is that it's made us all equal in many ways. And what's wonderful about it is that it's made us all equal in many ways. Now, as someone who comes from Black, working class, lower middle class background, I was of course incensed by her comments, as many people were, and she since deleted the post. We were concerned, about her blatant oversight in her analysis of how social inequality actually works. But the social scientist in me was even more intrigued by the fact that in 2020, the mainstream media and many others still haven't fully grasped the idea that a large portion of health outcomes in groups are socially determined, as opposed to biologically determined, and that social factors, many of which I've highlighted from her direct quote, here in red, as you can see, these social factors actually play a very significant role in shaping these outcomes that we're witnessing for different groups. Well, of course, by now we know, based on solid empirical as well as anecdotal evidence, that not only is the risk for COVID-19 unequally distributed among groups, but that the outcomes of COVID-19 are also patterned by race. And so today, I'll be giving a brief overview of some of the racial disparities that we're witnessing in the COVID-19 cases, as well as deaths. And then I'll briefly be discussing, why these outcomes exist. I think you could spend a whole semester on this. And then end by talking a little bit about how we can address these health inequities and what we can do today. Now, before I begin, I would like to acknowledge that there are some recent findings that show that the Navajo Nation in the New Mexico, Arizona, Utah region of the country have alarmingly high rates of COVID-19, and many have attributed aggressive testing approach as they've tested, I believe, almost 15% of their population. But we know that many individuals in this population live further away from hospitals, and a significant portion does not have running water, and this limits their ability to engage in safe practices. It's important for me to acknowledge this before I begin, because indigenous populations historically have been erased from many studies in this country. And given that my expertise is on Black Americans, the majority of my content today will be centered around their experiences. However, it's also worth noting that many of the issues that I will be discussing today can also be applied to understand the disparities that we see among other groups as well. So think about that as we move forward. So let's start with Michigan. This was a state that was talked about quite a lot among a few other states because they were one of the first states that collected and released early data showing that Black Americans there were making up about 31% of confirmed cases and about 40% of the deaths related to COVID-19. Now, this is particularly alarming given that Black people only make up about 14% of the population in Michigan, which suggests that Black folks in Michigan are significantly overrepresented among those who've been afflicted by this virus. And we can compare that with the fact that white Americans represented about 36% of the early confirmed cases and about 51% of the deaths, yet white Americans in Michigan make up about 79% of the population. They're the majority. And we can actually see similar trends if we skip to another state. We go to Georgia, which is located in a different region of the country. And in Georgia, Black Americans have the highest number of cases out of all racial groups, despite making up only about 32% of the population in Georgia. Now, while white Americans are the majority in Georgia at about 60% of the population, they still don't outnumber Black Americans when it comes to the known confirmed cases, keeping in mind that many of the cases were not reported as far as like the racial data that was associated with those cases. Now, of course, many have argued that confirmed cases as a measure of the impact of the virus may be somewhat of a volatile measure simply because we don't have enough testing to know the true number of confirmed cases. So deaths by COVID-19 might be a more robust measure for us to consider. So let's take a look at New York City, which was considered kind of ground zero, if you will, for the major spike in the country's cases. In New York City, what they did was they reported deaths, the death rates per 100,000 people. And here we can still see similar trends where racial minorities, Black and brown folks, are overrepresented among those who are negatively impacted by the virus, while white Americans, the majority of the population in New York, is underrepresented in, when it comes to impact. And then since we're here in Kentucky, I figured why not present on a little bit of the racial data that has been collected here. So in Kentucky, now these numbers are a little different. We see that 74% of the cases where the race was known were white Americans here in Kentucky, and about 14.5% were Black Americans. But this still follows the similar trends that we've seen in other areas, given that Black Americans in Kentucky make up only about 8% of the population here. So we still see the trends as far as proportions go. There are higher rates, they're overrepresented among the known cases, whereas whites, who are the majority, overwhelming majority in this state, are slightly underrepresented. Now this begs the question, many people ask this question and it's been answered in a multitude of ways, but why do these outcomes exist? Well, we listen to our public, officials and our leaders in research. They've stated that folks who are members of certain groups are at higher risk for severe COVID-19 illness. So folks who are in vulnerable populations, folks who are in prisons, older adults, homeless individuals, people who reside in long-term care facilities, as well as folks with serious underlying medical conditions, which I'm going to talk about in a moment, frontline workers, and then the last one is people from racial and ethnic minority populations. Now, as we know, minorities can be represented in any number of these categories. And we're going to talk about how those statuses are compounded in just a moment. But if we just think about Black Americans, because people, they wanted to know, why is it that Americans are at an increase, or more vulnerable to suffering from the virus? What we know, and how this conversation has been framed, is that this is a health crisis within a crisis, meaning there were already health disparities along racial and ethnic lines before COVID-19 began. So just a little bit about Black Americans, and this has been discussed extensively in the news. Black Americans are at an increased risk for negative cardiometabolic outcomes such as diabetes, heart disease, hypertension. But Black Americans are also overrepresented or at an increased risk for experiencing several health issues or underlying conditions simultaneously. And we also know that Black Americans are at an increased risk for excess mortality. Other research has suggested, and I will try to touch on this in a few slides, that Black Americans also have an earlier onset for poor health conditions. So for instance, hypertension, children who are Black are more likely to develop that than white children. We also know that if we just think about the social determinants of health, people who live in areas with higher exposure to environmental toxins are more likely to be vulnerable for the negative outcomes of this virus. And we know that Black Americans can also check off that box, unfortunately, as well as psychosocial stressors. Now, I'm not going to focus on stress a whole lot right now, but I would like to talk about the cardiometabolic outcomes and the comorbidities. Let's just take a look at these data that come out of the NHIS, where we can see that between white Americans and Black Americans, if we're talking about obesity, hypertension, and diabetes, those conditions are much more prevalent among Black Americans compared to white Americans. But on the far left, we can see this category of sleep. And the reason why sleep is important is because sleep is not only one of the most important restorative processes that our bodies have. I mean, we need it every single day. That's how important it is. But it can also reflect life experience. So if you're in a high stressful environment, where you live, where you work, for instance, that can impact your sleep. So that is a measure of other social determinants of health that I'll try to touch on as I move forward. But in the interest of time, I'm going to keep it moving. I want to highlight these bottom 3 points. Again, Black Americans are at an increased risk for an earlier onset of poor conditions. And this was touched on by Surgeon General, Dr. Jerome Adams, during one of the press briefings about a month or so ago. He actually held up his own inhaler because, as we know, this virus is it's largely a respiratory issue. And there are racial disparities when it comes to respiratory issues. And these respiratory conditions that are poorer can begin earlier for Black Americans. We know, for instance, and Jerome, Dr. Adams has spoken to his own experiences he grew up with asthma. He said he carries that inhaler with him every single day. Excuse me. And we know, based on research, that Black children have higher rates of asthma, higher rates of hospitalizations and deaths due to asthma, an increased risk for exposure to residential allergens and pollution. Of course, we're thinking about cities such as Flint, Michigan, who've been without clean water for several years now. But that's not the only study, or that's not the only case of disproportionate exposure to pollution that we know of. We know that children in New York, for instance, Baltimore, other residential areas are likely to live in neighborhoods and buildings where there's higher lead content. And all of these conditions can be exacerbated over the life course. It's just one thing that I wanted to highlight while we're here. And you can find more information about this in the Journal of American Medical Association, but I'm gonna try to keep it focused on COVID-19 today. So when people ask about, why is it that there are racial disparities in these health outcomes for COVID-19, it's commonly cited, that there are several social determinants of health that contribute to this. So for instance, if we think about living conditions, we know that due to residential segregation, which I'm going to talk about in more detail in a moment, Black Americans and other racial and ethnic minorities are more likely to live in densely populated areas, which can make it more difficult to distance yourself from the virus. We also know that many members of racial and ethnic minorities are more likely to live in neighborhoods that are further away from grocery stores and healthcare facilities, which can make it that much more difficult to receive care when they notice some symptoms or they want to get tested. We also know that racial and ethnic minorities often live in multi-generational households. Now, whether that's due to economic reasons or even just cultural reasons, and among racial and ethnic minorities, and it can also make it more difficult to take the necessary precautions to protect older family members or more vulnerable family members and socially isolate if you live in multi-generational households. And lastly, we know that racial and ethnic minorities are overrepresented in jails, prisons, and detention centers, which can make it that much harder to distance. Now, if we think about work circumstances, we know that racial and ethnic minorities are overrepresented or well represented, we'll say, in the essential workforce. We're thinking about industries such as public transit, healthcare, grocery stores, et cetera. That can make it difficult to work from home, as you can imagine. We also know that only about 1 in 5 Black Americans, for example, are able to work from home, based on a survey that was conducted by the Bureau of Labor Statistics. And we also know that racial and ethnic minorities may get paid sick leave. So moving on to the underlying health conditions, I spoke about that a moment ago, but we know again that racial and ethnic minorities tend to have those underlying health conditions, whether they be one condition or comorbidities that can make it difficult to recover from COVID-19. And we also know that racial and ethnic minorities have lower access to care, whether that's due to lack of health insurance or other barriers that I'll discuss later on in this presentation. These are all reasons that are typically cited for why we are noticing these disparities. Now, I'm going to take it a step further myself and many other researchers would do this, um, and ask, I know this is a rhetorical question, what is the common thread among each of these social determinants of health? And I'm going to go ahead and just give it away here. What I would argue, and what many others have argued, is that all of those issues have been structured by structural racism. And I'm going to explain to you all just how that is. So, if we think about the significance of race in health in this country, I'm going to try to go through a brief history lesson, if you all don't mind. Um, we know that as early as um 1899, when Du Bois was writing his seminal work on the living conditions for Black Americans in Philadelphia, in his book, The Philadelphia Negro, chapter 10, he talks very explicitly about how, even though at that time they were learning a lot more about biology, and they were making scientific advances, the causes of health disparities, particularly along racial lines, were primarily social. Now, as we move forward past the 1800s, and past the civil rights movement, the Civil Rights Act of 1964 and the Voting Rights Act of 1965, we start to see this legislation that improve outcomes for the quality of life of Black Americans and other racial and ethnic minorities. There was this notion that perhaps there was a declining significance of race. William Julius Wilson, a very renowned sociologist, he wrote a book about that and suggested that we should focus more. And I'm paraphrasing. He wrote a whole book, so I'm paraphrasing, but that more of the focus should be put on socioeconomic status. Now, what we know is that race and socioeconomic status are usually intertwined. And again, I'll touch on this in my next few slides when we start talking about housing segregation, et cetera. So those two items are not easily disentangled. But what we also know as a result of this is that even when we control for socioeconomic status, studies still found that at every single level of socioeconomic status, if we're talking about Black-white disparities, and I'm sure this can be measured for other groups as well, is that there were still differences in health outcomes, regardless of what level of socioeconomic status the participants were in these studies, which goes on to suggest that perhaps there's this added layer of what we call racism, which I'm going to define for you all, just to make sure that we're all on the same page. And then I'll tie this back to COVID-19. So first, it's important for us to know what racism is. Racism is defined as an organized system that categorizes population groups into races and uses this ranking to preferentially allocate societal goods and resources to groups regarded as superior. This particular definition of racism is very important because it highlights a structural component. If we think about, the first few words, an organized system, okay? We've heard structural racism used a lot in the media when people are trying to discuss why we're seeing these outcomes, but not many people actually break it down. So I wanted to just define what racism is, just to give you all another look at it. Other researchers have defined it as beliefs, attitudes, institutional arrangements. Again, this is a structural component that we're highlighting here when we talk about racism, and we think about institutional arrangements and acts that denigrate individuals or groups because of phenotypic characteristics or ethnic group affiliation. Now, this is not to be confused with what a lot of people think is racism, which is racial discrimination. Now, granted, discrimination definitely falls underneath the umbrella of racism, But racism is a system, again, going back to that previous definition. And racial discrimination or unfair treatment or bias is it is a branch off the tree of racism. So I just wanted to go ahead and define those for you all, so we can think about that as we move forward, as well as the structural component that that racism is. So if we think about how racism can affect health, I want to start off with residential segregation because this is a big one, and it's often talked about. It's even cited on the CDC website as a social determinant of health and a fundamental cause of health. I'm going to go ahead and use an example from my hometown, St. Louis, just to show how racial segregation in housing and socioeconomic position cannot be easily disentangled. So this graphic to the left of the slide, it shows an image of what is known as the infamous Delmar Divide in St. Louis, Missouri. Now feel free to read up on this in your spare time. There's a Wikipedia page on it. They've done specials on it, BBC, PBS, etc. And in St. Louis, Delmar Boulevard is one of the oldest main roads in the city that travels through the city from east to west. Now, without going through the entire history of the Delmar Divide, I'll simply note that in the early 1900s, during the Jim Crow era, St. Louis passed a residential segregation ordinance, as well as racial covenants that effectively prevented Black folks in St. Louis from moving into certain white neighborhoods. Now, this wasn't just for Black people, this was also for other racial and ethnic minorities, but at the time, that's who was in St. Louis. So now, while these covenants were eventually ruled unconstitutional several decades later, this structure was maintained systematically through phenomena such as white flight, other forms of racial discrimination as folks were seeking housing. Now, this is important for many reasons. One reason that is important is that we can see here clearly these data are from, if you look at the image, between 2007 and 2011, 5-year estimates. And we can see clearly that the remnants of Jim Crow have lasted over a century and many generations of families. So, when people try to act as if racism, is a thing of the past, and we all know that it's not, even if it was, the effects of Jim Crow legislation are still felt and seen to this day. And consequences of policies that were enforced over 100 years ago still have very hard, concrete effects on Black folks in St. Louis. And if I may, I'll just take a moment to go over some of the stats in the figure. As you can see on the north side of the city, the median home value is $78,000, whereas on the south side of the city, it's $310,000. On the north side of the city, the median income is $22,000, and about 5% of the residents have bachelor's degrees. Whereas on the south side, the median income is $47,000, and 67% have bachelor's degrees. And of course, you guessed it, the racial composition is also very disparate. We can see that on the north side of St. Louis, on the north side of Delmar, it's about 98, 99% African-American, and on the south side, 70% white. So again, we can still see the remnants of Jim Crow. And I don't want to spend too much time on that, but I also would like to mention that there's a lower life expectancy among the residents in North St. Louis. And as we know, where we live, it determines our access to opportunities to be healthy, trying to connect this back to COVID-19. And it also determines are resources. And when we think about resources, particularly in this moment in time for COVID-19, we know that testing has been a huge issue. Well, I would just like to show you all the same city, um, just to tie it back to COVID-19, the same city, they released data on the cases of the rates per 100 residents for the zip codes in the city of St. Louis. And I would like to um, just show you all this figure where you can see that um, the, there were higher case rates um, concentrated in northern St. Louis. And it's of no coincidence that these were the neighborhoods where most Black residents live. And these are the neighborhoods that were last to receive testing sites, whereas on the west side of St. Louis, or excuse me, West County, as well as South County, they received their testing sites about 2 weeks earlier. And that's significant time that's lost. So if I can go back to this slide here, I'd also like to point out that there's also a difference in people's ability to distance based on where they live. And if I can, I would like to show you, I hope you all can see this. Here is some location data. People used, I believe it was Quebec. I don't know if I'm pronouncing that correctly, but it's a company that uses smartphone location data, essentially, to determine where people were between February, mid-February, and late March, to determine, people's ability to distance based on their income group. Now, the wealthiest groups are going to be that blue line that you see, and the poorest groups are going to be that orange line that you see. And as the graph shows, and this was also shared in the New York Times if you want to learn more about it, because they have other figures. But what it shows is that the wealthier groups were able to distance themselves. They were able to slow down their movement, stay home, work from home, et cetera, about, on average, about 3 days before those who are in the lower income groups were able to do. And again, that's significant time that is lost as far as attempting to stop the spread of the virus. Now, just to kind of tie this back to race and what we see with confirmed COVID-19 cases over time, between February and May, we can see racial differences. We see that the white line that represents Black Americans and white Americans, for example, are in that purple line. I'm not really sure what color that is. It's a pinkish colored line. And again, it's no coincidence that groups who are lower in income, groups who are racial and ethnic minorities, particularly Black Americans, and as I said, all of that is intertwined. It's no coincidence that they were affected by COVID-19 at different rates. So going back to how racism affects health, would also like to talk about this key factor of racial discrimination. So we know that in the healthcare system, there are micro level factors that can impact COVID-19 outcomes, such as what we know about physician-patient interactions, for example. We know that studies have suggested that Black patients are usually spoken to instead of listened to, and this applies to other minorities. We also know that there is a phenomenon that's referred to as the racial empathy gap. So it's been well documented that Black and Brown Americans are less likely to receive pain medication compared to white Americans. And we know this based off of many studies. It's well documented, dating back to the early 2000s and even further. Um, if you wanna find some of that literature, um, and then even now we're seeing reports from Black and Brown individuals that they're being turned away from the ER, for example, at higher rates, even when they're presenting symptoms. Now, this next point that I would like to bring up is the rationing of ventilators based on benefit. So this is a very controversial issue, um, because we knew that the hospitals were going to get overwhelmed at some point. So people were discussing how the limited number of ventilators that exist might be rationed for patients. Well, one controversial criterion um, that they use to decide who would get a ventilator or not. And please forgive me if this isn't the case for all medical care facilities. I haven't been in any, fortunately, I've been at home. But there are some reports that suggest that they were using a model to predict, who would most likely benefit or survive after being put on a ventilator, and that's who would get the ventilator. Well, I'll put it to you like this. If you have two patients, one is a Black woman in her um, 40s, say for instance, she has underlying conditions, and the other is a seemingly healthy white male, similar in age or even younger than the Black woman, who do we think the hospital will be more likely to give that assistance to, that ventilator to? Keeping in mind that race is often wrongly stated as a prominent risk factor, in that uh, Black Americans tend to have a lower life expectancy. So if those are the agreed upon statistics, in many cases, um, it can be argued that the Black woman would be less likely to receive a ventilator based on that benefit or survival model. We also know um, that there's a long, dark history of mistreatment of Black Americans in this country. Harriet Washington, she actually discusses at length how Black bodies were experimented on for the purpose of scientific advancement in her book, Medical Apartheid. Feel free to check it out. Um, and what it suggests is that not only were Black Americans, mistreated during clinical trials, and even before then, during slavery when they couldn't say no, uh, it also suggests that um, Black Americans and other groups may be less likely to trust in healthcare systems. So, for instance, if we just look at these data here, um, let me see here. We can see for trust my physician, for that particular statement, um, about 80% of the white respondents said they agree with that statement, whereas about 43% of the adjusted non-Hispanic Black Americans participants said that they agree with that statement. I think that that's a stark contrast. Don't want to spend too much time on that, but it's important to note that that can be a deterrent for racial minorities seeking healthcare. Um, and this next one, you can even see, for instance, on the far right, we can see on the statement of hospitals have sometimes done harmful experiments on patients without their knowledge. We can see that while about 60% of the adjusted non-Hispanic Black Americans participants agreed with that statement, only about 30% of white participants agreed with that. And folks have argued that that's largely due to the fact that Black Americans are much more aware or even hyper aware of the mistreatment of Black people and other racial and ethnic minorities in this country. Lastly, in the interest of time, I'm going to talk about stress just a little bit, but In the interest of time, I'm gonna move past this race-related stress slide, but just I guess the important thing to note about stress, it's a silent killer, we know that, but we also know that everyone doesn't experience the same type of stress. We all have stress, but racial and ethnic minorities have that added burden of stress that's related to their race, whereas white Americans don't necessarily have that to the same degree. And there are some indirect consequences of COVID-19 for Black Americans. If we just, think about, some of these experiences that are listed on this slide, these are significant race-related stressors that racial minorities are enduring at this very moment due to COVID-19, starting with stigma. So for example, simply turning on the TV to get news updates on the pandemic, just to find out that yet again, you, your family, many of your friends and loved ones, people who look like you and come from your background, are at an increased risk for a negative outcome. That's stressful, as is often the case for Black Americans. And having to consider how people might treat you and members of your racial and ethnic group as a result of what's been reported and how it's been reported about this virus can also impact a person's well-being in a very subtle way. We also know that there have been heightened discriminatory acts against Black people, as well as Chinese Americans and others. So for instance, we've heard such stories like the one that comes from Cam Buckner, who's the state rep for Illinois, about how he himself was stopped by law enforcement after leaving the grocery store just because the officer said that his mask made it seem as if he was up to something. Now, other racial profiling has occurred in public spaces, and we know that from early data in Ohio, for example, the majority of folks who were arrested for breaking social distancing orders were Black individuals. And finally, given what we know about the disproportionate amount of Black folks who've been impacted by this virus, we know that there is undoubtedly stress from the loss and bereavement that is more prevalent among Black folks. And not to overshare in this space, but I know that my family certainly, has been impacted by it. Now, if I can move along to this last slide, I see I'm getting close on time here, or this last section of the presentation. I briefly want to talk about how we can address these health inequities. So first, I'm always going to recommend that people visit the CDC website. They have their own recommendations, such as working across sectors, partnering with faith-based organizations, for example, as well as community, connecting patients to community-based organizations that may be more equipped and more culturally ready to address the specific needs of members for that particular community or group. Of course, I encourage everyone to visit, but here are some of my personal suggestions for steps towards more health equity, particularly with this COVID-19. So first, of course, is simply acknowledging the long-standing structural racism and the history of that in this country and how its remnants, like I showed with the Delmar divide, still have strong, concrete impact, impactful effects today. When people talk about residential segregation, or they talk about how Black Americans are more likely to have this and more likely to have that, they stop short of acknowledging why. And the reason is not just because of housing segregation. The reason is that housing segregation was structured by racism at some point in this country. And I think that by not acknowledging that, that kind of absolves, this country and our leaders from that responsibility. But we also know that it is best to reduce implicit bias and discrimination in healthcare, not only for better health outcomes, but also to keep folks from feeling like they shouldn't be in a doctor's office when they need help. In the interest of time, I'm going to keep it moving. Also, racial data transparency, really quickly. Johns Hopkins Coronavirus Resource Center has been tracking the number of states that are presenting or collecting and presenting the racial data for testing, confirmed cases, as well as deaths. We see that when it comes to testing, only 3 states so far, or 4 states, um, are presenting that data. If we talked about confirmed cases, it looks a lot better, but still not all states are presenting that data. Now, there are some websites out there that are considered valuable, reliable sources, but I'm going to stick with the Johns Hopkins Coronavirus Resource Center as I trust them the most. And if we think about deaths, fewer states are reporting the deaths along racial lines. Um, and actually Kentucky is one of those states. Now you can go to certain websites and they will try to present some of that data. But again, um, um, I'm just gonna present data that I trust. So moving on to the one of the last pieces is that we need to think about how we can distribute resources based on need during during this pandemic and beyond. So as you just saw, this is a discussion of equality versus equity. So if we just look at this illustration briefly, as you can see to the left, equality, it implies that individuals will be given equal chances to reach the apple in the tree. But as we can see, equal footing doesn't necessarily benefit the shorter individuals the way that it benefits the one tall individual. Whereas models on equity, if we look at the right, those models propose that folks are assisted based on their specific needs. And as we can see, this is much more effective at ensuring that everyone can reach the apple, no matter how tall or short they are. Lastly, this is an illustration, of course, equality, equity, reality. There's a fence, folks struggling to see the ball game. And eventually, you know, all I'm trying to show at this slide is that eventually it would be nice if we could move past all of these and get to liberation, where there no longer is a fence and everyone can enjoy, you know, equal, equitable opportunities to be happy, healthy, and safe in the environments in which we work, live, learn, and play. So thank you for listening to my presentation. This is very strange for me, as I was telling the moderators before. I'm used to talking to people, but I feel like I'm just in my kitchen talking to myself. But feel free to contact me if you have any other questions. I know I kind of ran over a little bit. I also have a website, and you can find me on Twitter, just my name. And yeah, that is it. So thank you.
Well, thank you, Dr. Moody. This was incredibly enlightening, and I really appreciate you sharing the data and the information with us. I have to admit, structural racism is a new term, and I think that it's very interesting and very reflective of the organized system of racism. And you commented about implicit bias and discrimination in healthcare. And I was wondering, can you talk a little bit more about specific things we might be able to do to reduce implicit bias and discrimination as healthcare professionals?
Absolutely. And thank you for that question. I think, again, and I probably sound like a broken record when I talk to people about this, but it definitely always starts with acknowledgement. So knowing the history, for instance, you know, what I just talked about with housing segregation, for instance, a lot of people just kind of see that as, oh, well, you know, we woke up one day and Black people lived in that part of the city and white people lived in this part of the city. And that's why they're unhealthy over there and we're healthier over here. And to a certain extent, that's true, but we have to acknowledge the fact that the policies and legislation that was set forth to determine these outcomes that we see now were in fact spurred by racism at that time. Now, I think that in acknowledging that, you're then able to, if you're a healthcare practitioner, um, acknowledge your own biases that you may have. So when a patient comes in and they're Black or brown, do you see someone who needs assistance? Well, better yet, do you see a patient who is suffering, or do you see, just another Black person or poor person who needs something? And are you actually listening? When they're talking about what's going on with them, what's ailing them, or are you just kind of speaking to them? So those physician patient interactions can be improved drastically if we start there. We know, for instance, um, and this is kind of a sadder topic. Well, I mean, they're all sad, but if we think about the maternal um, or infant mortality rates, among Black people, oftentimes, if we think about the mother, and we've heard, anecdotal as well as empirically, that Black women often aren't listened to when they complain about excess pain or discomfort, and that can lead to the horrible numbers that we see in them perhaps not surviving, giving birth, or the baby not, reaching its full potential and being born prematurely. So I think that, again, it starts with acknowledging, that racial and ethnic minorities have systematically been oppressed through structural racism, and knowing what structural racism means, and then checking your own implicit biases, because we all have them. There are several studies that have showed that it doesn't even matter if you're Black or white, just because the way that race and inferior associations have been embedded, in our language and our psyche as a country. Oftentimes, we treat people in ways without even knowing it. So yeah, I think that checking your own implicit biases is a good start.
Okay, thank you so much. And I'll go ahead and turn it over to Jerome. I believe he has some questions from our participants.
Yes, ma'am. First question. Well, some of the questions have already been answered, so I just have a couple more that have not been answered.
Okay.
My first question. During the early phase of the COVID-19, I recalled reading about a spread of misinformation in Black communities that they were immune to the virus. Do you know the root of this source of misinformation, and do you think it contributed to the current numbers? And is this kind of misinformation still an issue?
Well, it's definitely still an issue. I can answer that one there. But yeah, so the source, I think that there are multiple sources. One, no one wants to believe, that they can get, the virus. I think that's the first thing there. So I think some people wanted to believe, that, oh, well, maybe this won't affect us this time around, because populations of color hadn't yet been hit outside of, Asia, as far as Black Americans, particularly in this country. I know in St. Louis, while the first cases, the first deaths were Black women in St. Louis, the first confirmed cases were not Black people. So I'm saying this to say, people who were traveling, people who were more wealthy and affluent, are the ones who were introducing the virus into, their metro areas. In St. Louis, for instance, many people told me, and I also read this, in the papers there, that it was first brought to St. Louis from folks who were in Italy. And the school that the child went to was in a very white, affluent neighborhood. So I'm saying all this to say, when it's something that you're not close to initially, and it seems like it's happening to other groups, you might want to feed into whether it's a joke, that Black people can't get it, or, a hope that Black people can't get it. Because at first Black people weren't necessarily that close to it. But what we know about social determinants of health and inequality and how, that can increase the risk for certain groups, as I stated, it didn't take long, for us to see, how Black Americans were being hit much harder, and Latino Americans were being hit much harder, as well as indigenous populations. So I think I answered all your questions, but essentially, it hurts. It hurts folks in the sense that if you don't think that you can get something, or if you're immune to something, you may not practice distancing as diligently as you probably could or should. And as I stated, if you wait, or if there's like a lag in, particular groups, I guess when they start distancing themselves from others or the virus, that can have huge, profound effects. Not only does it mean that that particular group might be hit harder, but now, those groups that were able to distance themselves, wealthier groups, whiter groups, if you're in the group that wasn't able to distance themselves, now you're at risk for forming internal clusters of infected individuals. And that's only going to exacerbate, this problem even further. And I think that's what we've been seeing.
Okay. Another question. Do you know of any recent or current studies or research that looks at similar racial differences and disproportionalities in both the US and Canada?
Yes, and that's a great question. One of the scholars that she's at the University of Toronto, and actually I shouldn't just cite her. Many folks have looked at how Canada, given that they have universal health care, for instance, how they might differ in outcomes versus the US, where we don't have universal health care. They found similar disparities if we talk about health outcomes. So the negative cardiometabolic outcomes that I mentioned earlier, they found similar patterns, similar trends, even after controlling for the fact that they have universal health care. And that more so strengthens the argument that there must be some added burden of perhaps racism or implicit bias against members from minority groups that can account for these outcomes that we're seeing. And when that's controlled for, we see that there is a statistically significant association between experiences of discrimination and poor health outcomes among minorities.
Okay, great. Just to remind everyone, this is being recorded and it will be on the Markey Cancer Center Affiliate Network resource portal. If you are a member of the affiliate network, you can send me an email and I will type my email in here. It's jerome.farley@uky.edu. If you are not a member and would like a copy of this presentation, you can send me an email. Make sure I spelled that correctly, and we will find a way to get it to you. Other than that, I would like to thank our presenter today, Dr. Myles Moody.
Thank you.
And our moderator, Ms. Sherry Toll. Thank everyone for joining. Have a great day and be safe out there.
Thank you, Dr. Moody.
Thank you for having me. You do the same.